Let's see the pleural effusions. Pleural effusions, first we need to assess if it is a transudative or exudative. We are going to use the light criteria. Light criteria is if we have one of three of the following, it is exudative, otherwise it's transudative. So the criteria are, we are going to measure the ratio of LDH, lactate dehydrogenase, in the fluid, in the pleural fluid, and we are going to divide this over the LDH in the serum. If this is less than 0.6, it is exudative. Other criteria is if the protein in the fluid over the protein concentration, over the concentration of the protein in the serum is less than 0.5, is exudative. We can take this, or if LDH, the concentration of the lactate dehydrogenase, is greater than 2/3 of the upper limit of the normal range of the lactate dehydrogenase. If none of this is accomplished, then it is a transudative. In transudative, we just have fluid, just fluid, that is in the pleural space. In exudative, we have fluid plus protein. So causes of transudative is increase in hydrostatic pressure of intracapillary, or diminished oncotic capillary pressure. Increased hydrostatic pressure would be in cardiac failure, congestive heart failure. We have increased pressure because the heart cannot pump, so we have increased pressure backwards until the lung, and then we have the pleural effusion, and so the patient has edema and all the characteristic of left heart. In diminished oncotic pressure, this is, for example, in nephrotic syndrome, we are losing albumin, and so the oncotic pressure in the capillary, we lose the protein, we have less protein that is pulling or is impeding the movement of the fluid, so protein goes here, and so the fluid. Usually, so the transudative causes are going to be bilateral pleural effusions. If we have an unilateral pleural effusion, we certainly need to consider a bacterial infection, that could be like bacterial pneumonia. Right now we're going to see all the causes of exudative pleural effusion. This could be malignancy. In malignancy, we have obstruction of the lymphatic drainage, so we don't remove the protein and everything that is in the lymphatics. And we will also see malignant cells in the pleural effusion. Malignancy, TB, pneumonia, etc. These are many causes. Could be pneumonia in relation to inflammation. These are just pleural effusion. If we have an exudative pleural effusion, we need to continue assessing it. So we need to take the cytology and measure the lactate dehydrogenase, the aldose. Also for some autoimmune diseases, we would measure anti-neutrophilic antibodies, anti-citrullinated peptide, and rheumatic factor. And also TB antigen, the antigen of tuberculosis. We can have complications from the pleural effusion. This would be emphysema and parapneumonic effusion. Parapneumonic is the effusion that is related to inflammation of an infection disease like bacteria. Parapneumonic, we are going to see now parapneumonic simple effusion, parapneumonic complicated, and empyema. Empyema is pleural fluid with pus. We are going to measure the how we are going to see it, the color. The color in simple pneumonic effusion is just cloudy, or could be even clear. Here is cloudy, and here is purulent. We have pus. Cytology, we see glucose, less concentration in glucose here and here, less glucose, and H12, C6 or 6. We have pH usually is between 7.3 and 7.45 in exudative. In transudative is between 7.4 and 7.55. But here we have in complication pneumonic pleural effusion, and in empyema it is less than 7.2, and here is greater than 7.2. And certainly the lactic dehydrogenase in everyone is going to be greater than 0.6. Well, the ratio. Empyema is just the pus and pleural effusion. This means colonization from bacteria in the pleura. Pneumonic pleural effusion complicated is continuous invasion of the pleura from bacteria, and this is just inflammation associated with bacterial pneumonia. Next, the cultive. Oh yes, also we need to take the cultive if the pleural effusion was exudative, we need to take the cultive. Cultive is going to be positive just for empyema, just when we have the colonization. And the treatment is antibiotics in each one, and drainage with chest tube for complicated pneumonic effusion and empyema. We need to remove the pleural effusion in order to prevent complications. The empyema could also be seen in lung abscess and bronchiectasis.